At this point in time, we had time for questions. We can resurrect the debate, or we can talk about other things. If anyone wants to come to the microphone, and let's have that discussion, which I think is so important.
Question?
All right, Max Mirko from Walnut Creek, California. My comment pertains to the previous debate about early versus late surgery for spinal cord injury. So I guess with all due respect, the basic science data and the observational data is not the basis for guidelines. From the rank and file perspective, it seems that the guidelines are coming from bias, are coming from intuition, are coming from the need to publish. And so basically, I just urge the people who are in the position to do it to make the randomized control trial. Otherwise, we're going to be in the same position 5 years from now, 10 years from now. It can happen. Where there's a will, there's a way. Put the biases aside, make it randomized, and we'll have our answer.
All right. It was a little hard to hear, but it sounded like you were saying you encourage a randomized control trial on timing of surgery and spinal cord injury?
Correct.
Okay. I mean, I'd like to answer that because, we just got a grant to do a trial on timing of surgery and spinal cord injury, which is what I was alluding to earlier. And this was a lot of debate and at least internal debate in my mind on what to do about this. And ultimately we landed, and I think, well, he's not here now, but, we learned from, Michael failings and the SASIS trial, there's just really no way to do an RCT on that topic, and there's first of all, there's the logistical issues, we're looking, because our hypothesis is that surgery within 12 hours is better. So, doing trials and trying to randomize people all within 12 hours is logistically essentially impossible. And then there's also the ethical component of that, right? So, who's going to sign up to be randomized to sit and wait, right? Can you imagine that conversation with a research coordinator and a patient and their family? We're going to randomize you, and we may operate on you now, or we might wait 12 or 24 hours or something like that. So that's ultimately why we landed on prospective observational, where we let the surgeon and the patient decide what they want to do, and we're just going to collect that data. And certainly it's not level 1 evidence, but I'm going to follow Lou's lead and make controversial statements. And I would say, show me one piece of level 1 evidence in spine surgery, and I'll show you why you're wrong. It doesn't exist.
So the other aspect of it is, and I think this is, instead of kind of saying you should or you shouldn't, maybe one of the things, the reason why there's a uncertainty is because we don't have all the data, right? So for example, if you have a head injury, we don't say, oh, you should do early decompression versus late decompression for head injury. And that's because if you have an epidural, that's going to be different from DAI, which is going to be different from, say, a subdural or a chronic subdural, right? So what we probably need to know is, and we're working on this right now, is probably being able to better understand our MR patients, right? And better understand our spinal cord injury patients, right? For example, if you've got a pressure and it's showing that there's axon damage, well, then maybe decompression is already too late. Whereas if you've got, imaging or some kind of parameter that shows that it's because of pressure, well, then maybe we should start to get the pressure off quickly, right? And until we understand the pathophysiology, there's always going to be that kind of debate because we don't know what we're doing, right? It's just like when you don't know what you're doing, you're going to have people who say, you need to do something. And there's other people who, if they don't know what they're doing, they're going to be like, no, don't do anything. You don't know what you're doing, right? So I think we need to better understand that pathophysiology and understand our patients better to selectively, properly choose. Just like GBM, right? We don't go, oh, every GBM needs to be treated the same. Now there's genetic markers and all these other things that we do to kind of understand. And I think that's where, as clinicians, we need to better understand our patients. Because right now, sometimes, in some of our colleagues, they just get a CT scan. We don't even know what's happening with the spinal cord. Right? Is there a hematoma there? Is there hematoma within the spinal cord? Is there a lot of edema? And I think if we understand that, we can better understand that concept of whether or not we should go early versus late.
But this is the issue. This is the real issue. We don't have complete information. So what Lewis said from Parr is very true. We need to control what we publish, and instead of saying guideline. This is really the debate about this. Before you say guidelines and all of this stuff, maybe you need to get the data first and all of that. The question I have is neuromodulation. Can you use neuromodulation early in spinal cord injury? the spinal cord stimulation, can you use it early in acute injury rather than chronic injury?
Yeah, so we kind of wanted to make a point about epidural spinal cord stimulation, but actually your point is very, very well taken, and that it may be better to use it upfront because it could potentially reduce axonal dieback. So that we do have some trials that are looking into that. But actually, I came up here to just make the point that all ASIA-As are not the same. You know, our ASIA grading system is extremely poor. Like, you have one patient who could be transected and another one who could have a contusion. They have nothing below the level of injury. But now that we have epidural stimulation, the patient who's transected is probably not going to really benefit much from that, maybe with autonomics, but obviously not with volitional movement. Whereas if you can maintain as many axons as possible through the site of injury, even if it isn't immediately obvious that you are saving something, that later could lead to that patient benefiting more from epidural stimulation, now that we have that on the research track. So I would like to really emphasize that our current grading systems are just not great. And one of the slides I showed about, like, 90% of people do have some volitional signals on electrophysiology, even if they are graded as ASIA-As, is, I think, really meaningful. So I want to make that point too, because I've been in a couple conferences where sort of it's been propagated that if it's an ASIA-A, well, you don't really have to take them to the OR, it's too late. But I don't think that's true at all.
Dr.
Thank you, Sanjay. John Hurlbert, University of Arizona. Quick comment for Francis. Congratulations on your elegant work. I always like to hear it on your, and I'm looking forward to duroplasty, how you're going to report that out. It's exciting field. But my question is, if you're going to add a graph to that, how are you going to overcome the subsequent 3 feet of regeneration in a non-permissive environment to try and get function returning distal to the injury? It's one thing to graft across an injury site, but it's another to get the graft to grow in that non-permissive CNS environment.
Yeah, no, John, you raise excellent points. If I had a chance, I would have described this study more in detail. The reality is, when we do these implants, we're not even sure what is really going on, what's actually happening. To a large degree, we're relying on a lot of data derived from our DBS and functional colleagues. The implants that have been inserted into the brain in these DBS surgeries, there's actually probably minimal integration of cells, but they are staying within or very close to the area of implantation, but still they're alive and they're producing growth factors. So we're not using this as a bridge per se, but as a little warehouse of growth factors, right, that can potentially persist for who knows how long in that environment.